Thank you. I want to thank the organizers and particularly Leo for inviting me to this meeting. And the organizers gave me the task to defend the treatment with long-term antibiotics and oxidants. I think each of them would deserve a session by itself. And I will try to condensate my thoughts about these two drugs in quite less than 30 minutes. So first, I didn't bring any conflict of interest slide because just, I would say, as an exception, I don't have any because I never receive a single euro for any company marketing macrolides or antioxidants. So I don't have any conflict of interest related to this talk. And having said that, I think that to set the scene, we have to recognize that there are patients with frequent exacerbations, and there are patients with frequent exacerbations despite the current treatments. And this is because, as I said in the previous debate, there are patients with different phenotypes. And it's not infrequent, at least in hospitals, in reference centers, to see patients with frequent exacerbations that have bronchiectasis. And these patients used to have frequent infective exacerbations, and these patients have a reduced survival. And I challenge you to try to prevent all exacerbations in these patients with bronchodilators and or inhaled steroids, and you will fail. Because by using bronchodilators and inhaled steroids, you will never solve the infective problems that these patients have. And in fact, you may even increase the problems, because we now have some evidence, something that we all thought, but there was no evidence, that by using inhaled steroids, the bacteria are very happy because they can grow better. And patients on high-dose inhaled steroids, if they have bronchiectasis, if they are colonized, they will probably have a stimuli to even grow more and have higher bacterial loads. And perhaps this can be an explanation why these patients also develop more frequent pneumonia. And at least my patients, not those patients in clinical trials who are 60 years old and have no significant comorbidities, but the patients in my clinic that are 75 or 80 with significant comorbidities, at the end of the day may even die because of a pneumonia. So we need other drugs, and it was also the conclusion by Nicholas in the previous talk. We need other anti-inflammatories, and we need to see if these drugs may be effective. And macrolides are an alternative for this. And this is for azithromycin, but it can be generalized in some way to macrolides. It has been seen how azithromycin may interfere in neutrophilic inflammation and may reduce neutrophilic inflammation and even interfere with the formation of biofilms. And that's why it has been very useful in patients with cystic fibrosis and in patients with bronchiectasis. And why not in patients with COPD and bronchiectasis, which are a significant number of our patients with COPD and frequent exacerbations. On top of that, macrolides have also an antiviral effect. And it has been seen how patients on macrolide treatment have a reduced number of viral complications. So going to the clinical studies, this is one of the initial trials with azithromycin, non-randomized, non-controlled trial, so have to be cautious when interpreting the results. But there was a dramatic reduction in exacerbations per patient per year in a population with very severe COPD, all of them with previous admission, frequent admissions to hospital. And these patients had a significant reduction when they were put on macrolides on top of the regular COPD medication. But this was just the first of a series, and I was not able to find a single negative study with macrolides in COPD, well, except one in just 30 patients per hour for 3 months, and who can see any effect in just 30 patients for 3 months. So this is the second by Francesco Blasi, again, in a particular subgroup of patients with special risks. And there was a significant difference in the rate of exacerbations. And this is interesting because when the patients stopped treatment at 6 months, after only a few months, then the risk was similar to the patients in the control group. So the effect disappeared after they stopped the treatment. Another one, looking at, again, in this case, was erythromycin. I don't want to bother you with the results of this trial. This is another. This is, again, not randomized. This is before and after treatment in a very severe population of patients with COPD, colonized with Pseudomonas, patients with frequent admissions to hospital with very poor lung function, and you can see significant and dramatic effects in reduction of exacerbations and hospital admissions in patients under this treatment, again, on top of the regular medication. And this is by the group of Wishes and looking at erythromycin daily and in severe patients with COPD, again, on top of the regular medication. And there was a significant effect in reduction of exacerbations. And then the landmark trial, a lot of people said, well, these studies were small, were in one single center, so we need a large trial, adequately powered, multi-center study with clear inclusion and exclusion criteria, well-controlled, placebo, blah, 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 and all the standards of quality. And this is a study, the American study in the NIH, and you can see a 27% reduction in exacerbations, on top, again, of the usual medication. So I think that we cannot just ignore these results, and we cannot write in our guidelines that there is not enough evidence or that this treatment should not be recommended. There is clearly a subgroup of patients that will benefit from this treatment. It's difficult to find in the literature, in the COPD literature. This is the tip of the iceberg. This is not what is creating the resistant problems in our community. The problems with the resistance in our community is due to the large number of children or young adults with just common colds or cough that are treated with macrolides. This is what is driving resistance really. And this is a nice study, again, from the group of London, looking at how many patients are treated in the UK with long-term antibiotics for COPD. And there was only 561. This is 0.6%. This is not what is going to drive resistance in the community. And on top of that, these patients, if they are really colonized, this is going to reduce the prevalence of resistant strains in those patients that are colonized. So what do the experts say about it? And I'll try to read it. So this is a paper in Lancet Respiratory Medicine. Look, the title. The title is not on efficacy, it's on risks. But despite focusing on risk, the final conclusion is that in patients with COPD, he suggests that only patients with recurrent exacerbations of significant magnitude and in whom all other preventable contributing factors have been optimally managed should be considered for macrolide treatment. Absolutely agree. Absolutely agree. This is the point. But another, and this is our chair today, is a co-author of this, and he said exactly the same, and I absolutely agree. It says, however, it may be considered for individual severe COPD patients with frequent exacerbations despite best quality guidelines-based treatment in those who are not at high risk of cardiovascular complications with close monitoring of hearing and after careful review of medications to avoid possible interactions. This is the target population. And these are the populations that will benefit from this treatment. So we cannot say that this treatment is not indicated in COPD. It's not indicated in general COPD. It's not indicated as a first-step treatment for COPD, but it's indicated for those patients in which it is indicated. And which patients have indication? Well, Wenzel et al. In this New England Journal, they proposed this criteria for the use of macrolide long-term treatment, which I, in general, agree with them. And in fact, there are some guidelines that have introduced that. This is the Czech Republic guideline based on phenotypes, and they identify a phenotype with bronchiectasis, and they recognize that only by using bronchodilators or anti-inflammatory drugs, we will not solve the problem for these patients. Also, the COPD Foundation guidelines, they also recommend long-term macrolides azithromycin in a subgroup of patients that have certain characteristics. In our Spanish guidelines, again, we put the possibility of adding long-term antibiotics here in the corner. I mean, as the last step, when you identify the right phenotype and after you have used all the available therapies. If you want to look at the different types of patients, we are now talking only about exacerbators with COPD, those exacerbators with chronic bronchitis, and particularly those exacerbators with chronic bronchitis and producers of dark sputum. Those are more likely to be colonized, more likely to have bronchiectasis when analyzed by CT scans. So just a few minutes about antioxidants. First, talking about efficacy, and by antioxidants, I will only focus on N-acetylcysteine. And this analysis of the different clinical trials is already 10 years old. All the different clinical trials looking at the frequency of exacerbations compared with the placebo arms, and there was a higher number of patients without exacerbations with NAC compared with patients in the placebo arm in the different trials. Different meta-analyses have shown an effect, and a small effect but significant, and probably because the quality of most of these trials was poor, and they were small trials, and we don't have a large trial until we had the bronchus, which was negative for the main outcome. But there was a significant effect on reduction of exacerbations in those patients not under ICS. What it suggests me is that in patients who have this, I call it, infective phenotype, in which I believe that inhaled steroids should not play a role, then we could substitute that by mucolytics and by macrolides on top of the regular medication. And this is the subgroup of patients in which these drugs, the N-acetylcysteine and macrolides, may play a role in preventing infective exacerbations in this infective phenotype of COPD. And we have new data. These are data in Lancet from China with a significant reduction with carbocysteine. But interestingly, those patients were probably not what we would say adequately treated according to our standards, because only a few were receiving inhaled steroids, or 15% only. But in this Cochrane review, finally the conclusion was that it is some effect, particularly in those patients who should not or do not receive inhaled steroids. And finally, this final study, perhaps there is an issue with the doses. By using 600 milligrams twice daily, there was a significant reduction of exacerbations in COPD, and in this case, even in patients who were on inhaled steroids. So I think that still, and we haven't heard the last data from this, and I think that in the future we will have more data that may suggest that perhaps there is a phenotype in which these drugs may have a role. So finally, long-term antibiotics are effective? Well, obviously yes. They are safe? Yes, but no drug is 100% safe, so we need to be careful with it when using long-term antibiotics or long-term macrolides in COPD, but it is clear that they are indicated in a phenotype of patients with COPD. But long-term antioxidants are effective? A small yes. Yes, but. Okay, so this is my point of view, and I will be very happy to hear Nicola's comments. Thank you.